30. Good evening, everyone. Myself, Dharti Rudani, embryologist at Snake Hospital, Jamnagar branch. Today's topic is interpreting and understanding semen analysis report. I'll briefly discuss semen analysis and common abnormalities. Male factor contribute to nearly 50% of infertility cases. A single semen analysis provides valuable information about sperm concentration, motility, morphology, vitality, and other several parameters, helping us decide whether a couple is suitable for natural conception, IUI, IVF, or ICSI. At our center, semen analysis is performed according to WHO 6th edition laboratory manual. The WHO provides standardized method and a reference value to ensure consistency across laboratories. However, this value should always be interpreted alongside the patient's clinical history. This is human analysis report routinely used in our laboratory. It includes both microscopic and microscopic assessment, providing a standardized evaluation of sperm quality. We can understand semen parameters like concentration, motility, and normal forms. Here is WHO reference values and a marker section over here. We also have a pie chart generated from the values we enter over here. On the next page of our report, we can write a comment section which we can give an impression of the semen analysis, and we also have few pictures of sperm from the slide.
बहुत मस्त patiently एकदम.
This video demonstrate a normal semen sample.
Patient સારું છે અત્યારે તો.
Sorry, I'll start again. Yeah. This video demonstrates a normal semen sample. Notice the high sperm concentration with rapid progressive motility, features that generally are associated with good fertilization potential. This report represents oligoasthenoteratospermia, where sperm count, motility, and morphology all are compromised. As the severity increases, the likelihood of natural conception decreases, making ICSI the preferred treatment in many cases. This video demonstrates oligoasthenoteratospermia. Compared with previous sample, you can see reduced sperm density, motility, and normal forms as well. This is oligospermia, characterized by reduced sperm concentration, fewer spermatozoa, reduced probability of natural fertilization, and treatment depends on severity and associated abnormalities. Asthenospermia refers to reduced progressive motility. Although sperm may be present in adequate number, poor motility limits their ability to reach and fertilize oocyte, often making assisted reproduction necessary. Teratospermia is characterized by abnormal sperm morphology, including head, neck, midpiece, or tail. In severe cases, careful sperm selection during ICSI becomes particularly important to optimize fertilization. Azoospermia is the complete absence of sperm in the ejaculate ejaculate, sorry, and requires further evaluation to demonstrate whether the case is obstructive or non-obstructive. Polysospermia, although uncommon, is characterized by unusual high sperm concentration, which may still be associated with reduced fertility due to poor sperm function. Leukocytospermia indicates increased white blood cell in semen sample, suggesting infection or inflammation that can impair sperm function through oxidative stress. Globosospermia is a rare condition in which sperm have a round head and lack of acrosome, preventing normal fertilization. This patient usually require ICSI. Cryptospermia or hidden sperm refers to extremely few sperm detected only after centrifugation. Then we have necrosospermia, which is usually stated as non-viable sperm and is only confirmed after vitality test. Hypospermia refers to low sperm volume, and aspermia is a complete absence of ejaculate. Both these cases, both these cases refer, both these cases require further evaluation to identify the underlying cases. This table demonstrates how semen quality influences treatment selection. As sperm parameters declines, the chances of natural conception and IUI decreases, while IVF and particularly ICSI become increasingly appropriate treatment. Treatment should always be based on both male and female factors. Advanced test. Routine semen analysis provides valuable baseline information but does not assess all the aspects of sperm function. In selected patients, advanced investigations such as DNA fragmentation, fructose test, MAR test, vitality test, oxidative stress test, and sperm culture can guide a clinical management. This slide highlights the key characteristics of an ideal sperm selected during ICSI, including progressive motility, normal morphology, and an intact acrosome, a healthy mid-piece, and a straight tail. The principle of sperm selection and their characteristics of fertilization and embryo development are extensive topic in themselves. Due to shortage of time, we'll be taking this session, we'll be continuing this part in next presentation. Male factors contribute to approximately half of all infertility cases, making semen analysis an essential part of infertility evaluation. Accurate interpretation, standardized laboratory practice, and appropriate clinical correlation are the key to selecting the right treatment and achieving the best possible reproductive outcome. Thank you for your time. I would be happy to answer any questions. Stop sharing.
Thank you so much, Dharti. So the session is open for the questions and any sort of query if anybody have.
Dharti,
Yeah, hello, sir.
વાંધો નહીં.
yeah, am I audible?
ખરેખર.
Yes, sir.
So, can any of the embryologists guide how do you specifically, or like you had mentioned a slide in which all characteristic of sperm were mentioned. There is a slide over there. So, yeah, sperm morphology related. So, can you, any embryologist can explain out of that normal sperm, which sperm on what criteria you are going to select? Because in XC, any days you are going to choose one sperm only. So what are your criteria when you are selecting a sperm specifically for the XC purpose?
Yeah, so during ICSI, we usually check entire sperm characteristics. Like we identify sperm with rapidly progressive motility. We usually choose sperm which is having rapid progressive motility. And talking about morphology part, we check the head piece. We also select the sperm which have acrosome present in it. We check the head piece, mid piece, neck, and tail. If there is any tail defect, I have already stated here. If we have any tail defect like this, we avoid selecting those type of sperm, and we select the ideal sperm which is in the center picture. Any head defects like this, we also avoid those. Any mid piece defects like this, we also avoid those. Yeah, so basically it depends on the all four characteristics, and on top of that, rapidly progressive motile sperm.
We are doctors together here. So there is one question from our side, like when you are doing ICSI, is there any role of motility? Do you give any preference to the more motile sperm in comparison to somewhat slowly progressing sperm in your slide?
So if I didn't understood wrong, we usually select more rapidly progressive motile sperm because they have more energy in them. So basically, in the mid piece, we have mitochondria present, which gives power to the sperm. And by selecting more rapidly progressive sperm, we also understand that that sperm might have more potential than any other sperm, which would be less progressive motile. So yeah, we do select sperm by their progressive motility. If I'm not wrong, sir, did that answer your question?
Yeah, we are here together. The question is uh, then that only that we have uh, many sperms in a single slide. Out of that, some are more progressive, some are less progressive. So, is there any criteria? Because this lecture or discussion we are taking on a motility angle only. So, is there any criteria? Then I think you answered it well.
Okay. Thank you, sir.
One more question I have.
Yeah.
Am I audible?
Yes, sir.
Have. If there is a sample where there are no normal sperm present, with no sperm with normal morphology, and if you have to select between three sperms, one is having a head defect, one is having a midpiece defect, and one is having a tail defect, which sperm will you select for it?
So I would like Nancy ma'am to answer this question, as she is already in a senior position. I think she would be the right person to explain it clearly. Nancy ma'am.
Yes. Sir, whenever we find during mostly during TESA, this situation comes that we have an abnormal
Okay.
morphology and a motile sperm, where we have to choose between a immotile and a motile sperm. So first of all, we have to choose the motile sperm with a normal head. If we have a normal head, we'll assume that the DNA is mostly protected. So if we have to choose between these three, we'll go with some with the sperm which have the more normal head at least, and the motility. Motility is also very important for if I have to choose between motility and morphology, I have first to go for the motility. That some sperm should be viable for ICSI, and then morphology. If I have all the options in the world where I have to choose the most normal sperm, I would go for everything. I'll see the motility also, I'll see the morphology also, everything normal, and then I'll take it. For normal ICSI also, what we do, we pass the semen sample through multiple preparation methods. We do double density, we do swim up, and then we put it in the PVP in the last corner, and then the most motile sperm comes to the other end, and then that from that end we take the sperm and then inject it. So it goes through double or triple layer of double or triple layer of what we call separation or filtration, and then we take that sperm for ICSI.
So one
Okay, then
question I had.
motility. Okay.
Yeah, please.
Yes, sure. Yes. So I was telling you motility is more important than morphology. That is what Nancy is trying to say.
Yes, sir. If I have the choice,
Okay.
if I have to choose between motility and morphology, it is definitely motility first, because sperm should be viable. Viability is more important. If a sperm looks normal, but it is not moving at all and it's not viable, so there's no point of injecting it. So motility is important. Morphology is equally important, but I have to choose between two, because mostly in TESA samples you can see that you'll see the motile sperm. Mostly the motile sperm in TESA samples sometimes are morphologically abnormal. And the morphologically normal some sperms are not motile. So if I have to choose between those, I'll go for the motile one first.
Okay, sure. Please, Deepa ma'am, go ahead with your question.
Yeah.